Hello, and welcome to this latest video from UK Heart Research. My name is Matt Ryan, Consultant Interventional Cardiologist at St Thomas's Hospital and Clinical Senior Lecturer at King's College London, and I'm delighted to present our new state-of-the-art review in JACC cardiovascular interventions on revascularization for patients with ischemic left ventricular dysfunction, a pathophysiology-guided, evidence-based approach. The finding of left ventricular dysfunction in patients undergoing percutaneous coronary intervention is frequent. Contemporary registries demonstrate that approximately 30% of patients who are undergoing PCI have a degree of left ventricular dysfunction, and as many of 10% of patients undergoing PCI have severely impaired left ventricular function. Despite this, left ventricular function is only assessed in around 50% of patients who are undergoing procedures, meaning the totality of patients who may be affected remains unknown. We do know, however, that left ventricular dysfunction is an absolutely critical driver of mortality. Many studies have shown that it is the most reliable independent predictor of adverse outcomes, with an up to 7-fold higher rate of mortality in the early period and extending out into the longer term. Our review article starts by reviewing the pathophysiology of left ventricular dysfunction, which can often be thought about as a spectrum, ranging from the first development of ischemia to myocardial stunning, whereas there is a persistent but ultimately temporary reduction in left ventricular function following an episode of ischemia. Recurrent episodes of stunning are thought to lead to myocardial hibernation, where cells can start to de-differentiate and have a more persistent impairment of function and contribute to longer-term left ventricular dysfunction and the development of heart failure. Ultimately, that may progress to advanced hibernation, which becomes irreversible, or we would hope recovery with removal of the ischemic stimulus. These are not just pathophysiological models, but are critical in understanding why outcomes may differ between patients with acute and chronic coronary syndromes, where in acute coronary syndromes, we're more often dealing with the management of stunning, and more chronically in the management of hibernation. Stunning is also critically important as it's a part of the ischemic cascade which may develop and result in patients deteriorating during a revascularization procedure. Our article is broadly divided into two sections. The first is to whom should we offer revascularization? This mostly focuses on patients with stable coronary artery disease and without very limiting angina. For patients with stable coronary artery disease and heart failure, historically, they would routinely be offered revascularization based on observational evidence. However, recent randomized evidence has very much changed our thinking. The first trial to note is the STITCH trial. STITCH enrolled patients with ischemic left ventricular dysfunction defined by having coronary artery disease and a left ventricular ejection fraction less than 35%, and randomized 1,200 of these patients one-to-one to either coronary artery bypass grafting or optimal medical therapy alone. They were recruited from 2002 to 2007 and followed up for up to 10 years in an extension study. After that period, for the primary outcome of all-cause mortality, a significant difference emerged favoring coronary artery bypass grafting, with a median increase in survival in the region of 18 months, indicating an effective treatment. Later important sub-studies demonstrated that this benefit was largely in patients who were younger, under the median age of 60 in the trial, had more impaired left ventricular function and more extensive coronary artery disease, suggesting that while there is the benefit, there may be some nuance in selecting who is taken forward. The second study we discussed is the REVIVE-BCIS-2 trial. REVIVE-BCIS-2 was a randomized trial enrolling outwardly similar patients from 2013 to 2020 in the United Kingdom. Patients had extensive coronary artery disease, left ventricular dysfunction, and evidence of myocardial viability, and 700 such patients were randomized one-to-one to either percutaneous coronary intervention and medical therapy, or to medical therapy alone. After a median of 2.4 years of follow-up, no difference emerged in the primary outcome of all-cause death or hospitalization for heart failure, indicating that PCI was not beneficial. There were important differences in the population, however. Patients in REVIVE were on average 10 years older and had a higher rate of things like implantable cardioverter defibrillators. A subsequent combined analysis in European Heart Journal earlier on this year demonstrated that there were such substantial changes in the medical therapy and the baseline characteristics that direct comparison of the two trials was largely meaningless, indicating that we need further data to compare PCI versus coronary artery bypass grafting alone. We touch briefly in the article on the role of viability testing with a range of modalities, MRI, PET, stress echocardiography, and review the evidence base. Overall, from the viability sub-studies of Revive, Stitch, and other trials, there is currently no evidence to take a viability-guided approach to intervention, although we acknowledge that there are wider uses for these techniques in patients with this condition. However, it should not be the absolute arbiter of whether or not someone undergoes a procedure. We then go on to take a look at medical therapy for these patients, which is a cornerstone regardless of the decisions around revascularization. We look at the role of antithrombotics, anticoagulants, the specific management of medication for heart failure, lifestyle interventions, device therapy, and lipid lowering. And whilst many of these drugs are used, the evidence base for them is highly variable, and I think an important part of the article to read. What we then come to do is look at how we ultimately make these decisions. How should clinicians and patients come together to do this? We discuss the role of shared decision-making and the importance of a well-functioning collaborative heart team in ultimately making the best decision for the patient and their family, friends, and loved ones. The second section of the article focuses very much more on how we should perform PCI in these patients. In the first section, we explore the human factors and the organizational role in achieving success in these patients. We look at how to prepare for performing PCI in a patient with ischemic left ventricular dysfunction. We look at how to make a PCI plan and how to manage strategies at both an individual, departmental, and organizational and institutional level in order to achieve the very best outcomes. We consider the structures that should underlie the decisions to take these patients forward and what mitigations and preparedness needs to be put in place to assure a good outcome in these settings. The biggest risk to patients with reduced left ventricular dysfunction undergoing PCI is that they enter an ischemic spiral, where either abrupt ischemia from a complication or attritional ischemia from recurrent balloon inflation triggers a downward trajectory of worsening contractility, worsening perfusion, and ultimately develop a cardiogenic shock. We take a stepwise approach to predicting and managing this, first looking at how we prepare for a high-risk PCI, considering how we obtain pre-procedural hemodynamics and how they might be optimized to reduce the risk of deterioration. We then look at what the responses should be when we start to have a reduction in cardiac output, how we can minimize ischemic time and target our intervention to ensure that the patient remains stable. If we enter a setting of reduced perfusion, we look at initial measures to maintain blood pressure and support the patient, and then ultimately look at cardiogenic shock, ideally from the point of view of prevention, but then also in terms of how we manage and retrieve a patient who has developed early signs of cardiovascular collapse. We look at what are the specific high-risk features within these patients, and we divide this into three areas. The first is the coronary anatomy. Do they have very complex disease? Is this a final patent conduit, or do they have a very high myocardial jeopardy? Are you going to cause a deep or broad area of ischemia when causing the intervention? The second are procedural characteristics. Is this a retrograde CTO? Is there left main stem calcium modification? Is there multivessel calcium modification? Again, these are markers of both attritional ischemia and recurrent long periods of ischemia, and also a higher risk of complications and abrupt cessation of flow in a vessel, which may lead to deterioration. Finally, we look at the left ventricular characteristics. Classically, this was looked at in terms of left ventricular function and certainly is in observational studies, but we can take a more granular approach, looking at left ventricular end diastolic pressure, valvular heart disease, and indeed very carefully characterized hemodynamics prior to undertaking a procedure. We then look in detail at various avenues of how to make these procedures safer. We look at pre-procedural optimization. What can we do to try and reduce the chance of these problems happening? We look at planning, things like vascular access, our bailout plan and escalation strategies, and also defining the point at which we're planning to stop because we've achieved success. We look at intra-procedural hemodynamic monitoring, consider things like dual operators, having two consultants working together, and how we adapt our strategy from the initial plan in order to achieve the best outcome. For the post-procedure, we look at appropriate aftercare. We look at team debriefs and clinical governance and audit, and how they can support maintaining an outstanding complex PCI program. Finally, we take a look at forthcoming trials, which will critically inform the evidence base in this area. One of the key unanswered questions is the role of elective mechanical circulatory support in patients undergoing high-risk PCI. We look here at two randomized trials which will help to answer this question. CHIP-BSIS-3 is a UK-based randomized controlled trial enrolling 300 patients undergoing high-risk PCI with left ventricular dysfunction. Those patients are randomized on a one-to-one basis to either elective mechanical circulatory support with a percutaneous left ventricular unloading device, or standard of care. The primary outcome is a win ratio with a hierarchical composite of death, stroke, myocardial infarction, hospitalization for cardiovascular causes, and periprocedural myocardial infarction. PROTECT 4 is an international study of 1,200 patients, again exploring the role of elective left ventricular unloading. In that trial, patients are randomized to either a percutaneous left ventricular assist device or to standard care, which may include an intra-aortic balloon pump. The trial has a primary outcome, again, of a combined MACE event at an initial point of 1 year and up to 3 years. Both trials are expected to publish in 2026, and we're excited to see the results come forward. And in the article, we consider how this may impact our strategies going forwards. We also take a look at the forthcoming Stitch 3 trial, the International Stitch 3 Consortium. This is a consortium of several international randomized controlled trials, which are randomizing patients with an ischemic left ventricular dysfunction to either cardiac surgery or percutaneous coronary intervention. Each individual trial is powered for composite outcomes, but the multinational collaboration is intended to look for an effect on mortality across this population, critical evidence that will be forthcoming. So in summary, our state-of-the-art review looks into how we can best revascularize patients with ischemic left ventricular dysfunction, starting from case selection through decision-making, PCI planning, the procedure, and the post-procedure period, and off into the future. All of that, all the way through, supported by key shared decision-making, the heart team, and provision of outstanding goal-directed medical therapy. Writing this article was an incredible opportunity to collaborate with colleagues around the world who are experts in the management of these patients, and we were delighted to be able to work with them to bring together what we hope will be the definitive article on how to manage these patients, and both a practical and evidence-based document which will support people's practice around the world for years to come. I hope you've enjoyed listening to this presentation, and I'd encourage you to look at our article, which is out and open access in JACC Cardiovascular Interventions today. Thank you very much for listening.